So this is entitled The Relevance of Recent Technological Advances for Everyday Endoscopy, exploring the intersection of AI and endoscopy, and in particular we will focus on the lower GI tract and colorectal polyps. So the objectives of this session are to demonstrate the potential advantages of accurately measuring size in colonoscopic practice and outline the potential of artificial intelligence-driven characterization in everyday endoscopic practice. A question for you all out there, if you're still there watching. Actually, the numbers of people watching are increasing towards the day, so I guess that's got something to do with time differences and everything and people coming home from work. You're all very welcome. Chance to win 10 GIEQs coins. What is the accuracy of a human endoscopist? And I should have inserted in there, in one study, obviously, because this could be completely different depending on which human endoscopist. If you put me and John together, mine would obviously be answer A and his would be D. No offense.
Yeah, you oversize everything.
Yeah, exactly right. What is the accuracy of a human endoscopist in determining the size of polyps? Is it A, B, C, or D? Right, vote on that. Now, I'm just looking at the live room in the side of my vision, thinking that they might be ready to show us something. So, are you there, Yuichi?
Not yet.
Okay, so first we'll go on to a talk then. And that's actually quite nice because this session is structured around devices to look at size. Let's have the first presentation, please. Devices to look at size, and then devices which can detect and then potentially characterize polyps. So I'll start off with, does size matter? The clinical relevance of new devices which can accurately measure polyp size. So the intention is in 7 minutes to understand the traditional way we do this and to explain a little bit why it's not very good, to explore the application of AI and other devices in enhancing the accuracy of polyp size management and measurement, evaluate the accuracy of AI compared to conventional assessment methods for polyp characterization and detection, and discuss the potential clinical implications of both. So does size matter? Well, size matters because we use it for many different things in our endoscopy practice following guidelines. So we use it to assess cancer risk. The bigger, the more risk of cancer. We use it to select resection method. ESG guidelines suggest that if you've got something under 10 millimeters, you pretty much always should do it cold snare. Whereas if it's bigger, then it's something else. We know from data that some of which I was lucky enough to work with Michael Burke on in Sydney, that recurrence after polypectomy is more common, the bigger that the lesion is. We know that surveillance intervals are almost directly related to the size of what you detect, in addition to the number and the pathology within. So size matters because it commits the patient to a certain track in terms of their follow-up. This device called ScaleEye, a laser measuring device from Fujifilm, is aiming to change that by using lots of complex mathematics, which I don't pretend to understand, to measure the polyp, either using this little scale type image, which we're just going to be demonstrated live, or to demonstrate the other way around. And we'll skip this because I don't think it's relevant for now. Just a question you might ask yourself before we see Yuichi demonstrate this is there some evidence for this, or is this all just something where, because one of my pet peeves in endoscopy practice is people just using technology because they have it and without there being any evidence for it. And actually there is some evidence for this, that ScaleEye is or this endoscopic measuring device is more accurate than a human endoscopist, and so there is some evidence for that. Before we see a demonstration of that, let's also talk, because there are other ways of scaling polyps, and I know maybe Raf's going to talk about this as well in his talk, artificial intelligence for sizing. I was just looking for publications, and thanks to Xander for helping me with this. There are 1, 2, 3, 4 publications, solid publications I could find about sizing, and we'll go into what they look like. One nice one is called Poseidon, which uses the water jet as a reference. And anyway, I'll show you what they look like in a minute. But if you just have a look at this, they are all all right in their accuracy, some a little bit more than others. But when you compare them to the reported accuracy of using a biopsy forceps, using a snare, using whatever else, they are significantly more accurate. This is one of them. Based on retinal photography, it's got something to do with measuring the vessels, making some distance between them, and then sizing up the polyp in the distance. So you see the polyp here. There's this one, which is using the water jet and knowing the diameter of the water jet at the point, and then sizing the polyp according to the water jet. Great name. Whoever came up with that, great name. The UNet positive network, which uses an open biopsy forceps right next to the polyp. Of course, if it's right away from the polyp, that's not going to be helpful to measure the polyp based upon the known size of this instrument. So there's many things. And to conclude, I just want to say, well, what does that mean for our future practice? And I think it means that it is quite clear that there are devices coming along, whether they're AI or not AI, that can make accurate measurement of size possible. But of course, all of the guidelines that we have were based upon humans interpreting size. So how does all this relate to those guidelines? I think that's going to be a period of transition when we figure that out, because some of the things that we thought were true before maybe are not true. I think so. Maybe we can get Nika to present the case, because I see her there ready to go, and then take it away for us.
Yeah, so this is a 74-year-old man with a family history of colorectal cancer. In May, he had a colonoscopy with detection of 23 polyps, for which he was referred to our center. This summer, we already did an EMR of multiple tubular adenomas with low-grade dysplasia, and also 2 times an ESD of what appeared to be intramucosal cancer on pathology. Genetic testing for hereditary syndromes is ongoing. And the main focus of the endoscopy today is to resect a 20 millimeter large polyp in the colon transversum, and also resection of multiple other smaller polyps, which are still there.
Great. Yuichi, do you hear us?
Yeah, I can hear you. Can you hear me?
Can hear you really well. So thanks again for being here, Yuichi, and take it away. Show us what the technology can do.
Absolutely. My pleasure to be here together with the fantastic colleagues here in Gang. So right now, even though the main purpose of this examination is removal of big polyp, my presentation or demonstration should be focused on polyp assessment with use of the new technologies provided by Fujifilm, namely CAD-eye and Scale-eye, which David, you just presented in a great manner. So right now, I don't use either CAD-eye nor sizing Scale-eye. So the question from my side to maybe the audience or the panel members or you, David, is, can you find any polyps in the screen?
Yeah, I mean, I think I can see one. What about everyone else? I can see maybe 2.
Three.
Yeah, 3.
Maybe 4.
Maybe 4.
Maybe more. I don't know. But it's sometimes very difficult to identify all the polyps on the screen because of the lack of the attention or maybe lack of the expertise. So let us activate AI to strengthen our confidence in polyp detection. So right now, CAD-eye is activated so that these 2 polyps, at least 2 polyps, are detected almost at the same time, which is a great value, I think. Maybe the detection is the first step to prevent colorectal cancer. Then, next thing might be the measurement of the size or prediction of the histopathology. Which one is preferred as a second step, David?
Well, I think the next step is to measure the size of them, because to be honest, I think most people would agree if they're under 10 millimeters in size, then the risk of cancer is low. That's step number 1. And then step number 2 is to figure out if they need resecting. And that is where I think potentially you could get some benefit if you're inexperienced in optical diagnosis from CADX.
Absolutely. I agree with your idea. So let's measure the size without use of the technology with your eyes. Maybe you can utilize the diameter of the cap by approaching the polyp like this. Or maybe you can predict the size with use of your experience or your brain. I'd say it's around 1-2 millimeters. But some endoscopists may predict the size. Maybe it might be 3 or 4. I don't know. It depends. But right now, Fujifilm provides a quite interesting technology, which is called scale eye. So I'm gonna activate the scale eye here. So there's some tip to optimize the value of this technology, which is the point of the laser. So laser should be placed just close by the polyp. So here you can find, so the location of the laser is quite important to provide an accurate measurement. So like this, the laser should be placed just beside a polyp or on the very edge of the polyp. Otherwise, it's going to be difficult to measure the correct size. So here you can find a measure with the 5mm, 10mm, and 20mm. And I recommend you use the freeze button or pause button so that you can objectively assess the length of the polyp. So here, based on this scale, I would predict this polyp is 2mm in size. So be careful about the plane of the target. So right now we can find two polyps on the same screen. However, the plane or level is different because the left one is more distant while the right one is a little bit proximal. So you can't utilize this scale for both polyps because these polyps are located on different levels. So for example, if you utilize this scale on the right side polyp, maybe you can say, oh, this polyp is a 4 or 5mm, because the scale is suggesting this kind of size. But be sure that scale eye should be used in an appropriate way. So if you want to measure the length or the diameter of the polyp on the right side, you should change your focus from left to right, like this. Then you can measure this polyp in a more accurate way. So I would say it's around 1-2 millimeter based on this measurement, maybe 1.5 millimeter. What do you think about this, David?
It's a really beautiful demonstration, Yuichi. Thank you so much. So really great that there's that folding away, and if you look at the right side, you can even think it's maybe 10 millimeters large, whereas the left side, it's very clearly exactly as you predicted, 1 to 2 millimeters in size. Have we got some comments from the audience? So I'm looking at Raf, I'm looking at Steve.
That's a very nice demonstration. I just had a question regarding the detection mode, Yuichi, that you just showed. It appears to be that it takes a little bit of time, especially if you move for the boxes to become stable in terms of segmentation, delineation of the polyp. So does this affect the way you retract the scope when you use AI systems? Should we do this more slowly in order to allow the system to detect polyps? What do you think?
Ralph, that's a great question. With regard to this technology, I would recommend retrieve endoscope a little bit slower because of the fact you mentioned right now. But if the technology developed much more in the future, maybe this kind of thing should not be taken care of because the speed of detection might be much faster than human being.
The polyp size is important. You already said why this is important, so I'm not going to go too detail in that. But if you look at the guidelines, it's clear that everything is determined by 10 millimeters in terms of follow-up. And also for serrated polyps, this is important. When we want to apply the resect and discard strategy to 5 millimeter cutoff is important. And also how we need to assess these polyps. We need to apply advanced imaging for characterization once we pass that 10 millimeter border. An overestimation will lead to too frequent colonoscopies or the underestimation of size to underestimate the risk of colorectal cancer. And we're not good at this. We actually tend to go to the 5 or 10 millimeter threshold. So where are we now for characterization with artificial intelligence? Well, there are several systems available nowadays that are either commercially available, and there's a lot of development going on also academically. And studies show in general a large variability in diagnostic accuracy between studies and also for different studies, for different systems. The most systems do currently not include differentiation for SSLs. The research is going on there, and there's currently no system to predict invasion depth. And sizing, as you can see, is available on the Fujifilm scopes as a visual scale tool. Here you can see the diagrams that John was referring to. You can see that the polyp will turn yellow if it's an adenoma, and it turns green if it's a hyperplastic polyp, as you can see here. So you can see this heat map. And you can see already immediately in these two different smaller size studies that, in fact, in terms of characterization, the outcome per study is quite different. And you have like an accuracy of 95%. Here, better than the endoscopist, and here 83%, not so much better than the expert endoscopist. So there's a bit of variability in the results. Why is that? I don't know. But what do we need in the future? So I think we need further improvement of performance of many systems. We're not there yet. And certainly we need larger trials in real-life setting and incorporation of these SS-associated lesions, and preferably also an expansion to larger lesions to help us to predict invasive cancer. But I think in the end, acceptance of this resect and discard strategy, which is very promising in terms of money saving and also green endoscopy, will depend a bit on the reimbursement. So, is it therefore already relevant to everyday endoscopy? Well, probably if you're going to send everything to pathology, not so much. But I think it can definitely help you if you want to apply the discard strategy in your daily practice to have some additional aids and support when you're in doubt about small polyps. So in conclusion, I think it's clear that optical diagnosis can be cost-saving and that current systems of AI can help to improve the confidence level when endoscopists are making an optical diagnosis. However, many systems do not reach yet the current SODA or PV standards and need further improvement. So there's a lot of work to be done. And I think we can also see that the visual scale assistance that we have with the Scale Eye is really improving better sizing and can improve the quality of patient care by avoiding too frequent colonoscopies by overestimating the size. Thank you again for the invitation and for your attention.